Welcome, and thank you for joining us for the International NASH Day panel on NASH as a Global Public Health Challenge. My name is Donna Cryer. I will be your moderator today. We are one of 6 thought leader webinars that are being conducted across time zones throughout this International NASH Day as part of a recognition of International NASH Day, or IND, which is an initiative of the Global Liver Institute in partnership this year with 80 different organizations in 25 countries. We are so honored that so many organizations be willing to work together on this great public health challenge. This year, because of the pandemic, because of these special circumstances, IND is being celebrated as a virtual multi-platinum platform experience. So whether you are viewing this on Zoom or on Facebook or Instagram or Twitter, we welcome you and we thank you. The purpose of all of this activity is to raise awareness about NAFLD, non-alcoholic fatty liver disease, and NASH, non-alcoholic steatohepatitis, on which you'll learn more about in this conversation. We also want to spark a global movement of action. So not just raising awareness, but spark some actions to improve the lives of people who are at risk for or are living with NAFLD and NASH. Please visit our website, globalliver.org. Follow us on Twitter, Facebook, and Instagram using the hashtag NASHDay. A special thank you to AASLD, the American Association for the Study of Liver Diseases, and to AASLD, the home of hepatology, a European Association for the Study of the Liver, for endorsing International NASH Day and for partnering us in such a special way. We also want to thank our corporate sponsors who are listed here. We really could not do this without your support. I also want to recognize someone who's not on this panel, Inova, who has helped us put the IND logo on NASDAQ. So we are conquering Times Square today. I do want to say, though, a thank you to our NASH Council corporate partners as well. But as I'm seeing on social media, for those corporations who have co-opted the message without contributing to the community, shame on you. Shame on you. So now, though, I'd like to introduce our august panel for the topic of NASH as a global public health challenge. We have with us Dr. Raymond Chung, who is the AASLD President-Elect. He's at Harvard University. We have Dr. Zobair Younossi, who is president of Inova Medicine Services and chairman of clinical research for Inova Health System. Zobair has many, many titles. Pavel Bogomolov, I'm going to say that right eventually. I need to put my hands on my hip and get my sort of Russian confidence and attitude on. But thank you so much, Pavel, for joining us today. We have Marko Korenjak, who is president of the European Liver Patients Association. To all of you, welcome. So I'm going to take a moderator's prerogative for a moment and just set this up for us, and then I'll turn it over to Dr. Chung. So NASH has been described as a tsunami, as a silent epidemic, but from the Global Liver Institute perspective, we have always considered this a public health challenge. From the launch of our NASH Council in 2017 at the Milken Institute School of Public Health, we have wanted to position this as a part of the public health conversation, as part of a public health mission. And the NASH Council has now grown to more than 70 members, organizations in medicine, nursing, community building, and advocacy, representing not only hepatology and gastroenterology, but also endocrinology, cardiology, and that's been by design from the inception. And so we've thought that NASH represents a really unique opportunity that we've never really had before in the liver health space to broaden the group of stakeholders who cared about liver issues, liver patients like myself. I'm 25 years post-liver transplant, very privileged, very blessed, and who care about liver health and who feel a sense of ownership that this is their issue as well. And so Dr. Chung, as the President-Elect of AASLD, I would love if you would start us off, particularly speaking about meeting this moment of keeping the focus on liver health during the time of the global COVID-19 pandemic.
Yes, thank you very much, Donna, and hopefully you all can hear me. I am privileged to represent AASLD as a delighted endorser of this program, International NASH Day, and of the Global Liver Institute, with whom we've enjoyed a very long partnership. And as Donna just indicated, part of AASLD's mission, which of course is to provide information and research for the treatment and prevention of liver disease, we are committed to the support of NASH as a major public health problem, and certainly a major problem among those who care about patients or care for patients with liver disease. As you just alluded to, Donna, one of our major commitments has really been to respond to the moment, and that moment has really been dominated by the COVID-19 pandemic. We've seen extraordinary morbidity and mortality associated with that, and certainly it touches all of us in humanity, but certainly those of us who have chronic forms of liver disease. We've already seen that COVID-19 worsens the course of chronic liver disease, particularly those individuals with advanced liver disease, and that we're witnessing as well an emerging picture of predisposing factors like age, cardiovascular disease, diabetes, and obesity. And interestingly enough, of course, buried within that, it appears that fatty liver may also predispose to more severe COVID-19 disease. So in many ways, COVID-19, the current pandemic, has laid bare other underlying epidemics of chronic disease, of which NASH and fatty liver disease are a predominant or prominent part. And really underscores, I think, this parallel pandemic of NAFLD NASH, which, like the COVID-19 pandemic, is only growing globally. And AASLD, I think, has been positioned to play a key role in really educating the public, both providers and patients, about these emerging pandemics. And so, in the context of COVID-19, we have developed a very rapid response insofar as providing up to the moment information to those who take care of patients with chronic liver disease about COVID-19 and its impact on those patients. This has come in the form of real-time information regarding emerging clinical insights for management of patients with chronic liver disease who are living in the time of COVID. And this is translated into not just real-time documents and published documents, but also a series of webinars. We've already conducted 5 webinars to very large audiences and are planning 3 additional webinars on topics of great relevance to not just providers, but also to patients as well. We have also, in addition to our published and webinar material, created care communities on an online community called Engage. And these have all represented our sort of up to the moment efforts to respond to this pandemic. So in a similar vein, then we have made a decision strategically to really historically we have been an organization that has had relatively limited interface with patients, but with our new strategic plan, we've made a commitment to really cross that threshold and engage patients actively. And this has come in the form of a variety of different initiatives, including patient registrations at the liver meeting, beginning with last year's liver meeting and continuing certainly for future meetings, to create a patient villages and areas at the liver meeting where patients can congregate and to meet not only with each other, but also with other stakeholders in managing liver disease. And certainly information provided to patients. And in that regard, we have just emerged with a patient flyer that is directed at patients who have chronic liver disease, or those who need liver transplants, or those who have received liver transplants, and provided direct patient material for what COVID-19 means for them on our webpage. So this is really only the beginning, I think, of a long engagement and relationship with patients as it relates to issues highly relevant to them. And so in this regard, NASH represents, of course, a major frontier for this organization, the GLI, as well as for us at AASLD. And in that regard, we have created a NASH task force whose charge is really to design new initiatives to improve outcomes for patients with NASH. And this has taken many different forms already, and I'd like to just cite a number of them. We have, just as you spoke about partnerships with endocrinology and cardiology, we have made a clear-cut strategic decision to partner, again, in generating dual or triple society practice guidelines with our colleagues in endocrinology, first around patients with diabetes, and then I think, generally speaking, across all patients with NASH, NAFLD, cardiovascular disease, and endocrinologic disease. These will come in the forms of joint symposia and multidisciplinary educational sessions, but as well the development of practice guidelines. As well, we have already developed a strategic partnerships and collaborations with patient groups, so-called patient advisory groups, such as GLI and many others, to raise disease awareness. And NASH clearly sits at the top of the list among those conditions on which we will venture in partnership with patient groups to promote not just best practices and treatment strategies for managing patients with NASH, but also to promote interdisciplinary research advances. To this end, we have also sanctioned a so-called white paper, which is a position paper on the role of liver biopsy in patients with NASH and NAFLD. And of course, the development of updated NASH practice guideline development, which will become fast and furious as we anticipate new drug approvals in the space of NASH. And in this regard, I do want to say that we will have to depart from our old traditions of published guidelines that come out once every several years, but rather develop, much as we did with hepatitis C, a living document that reflects a rapid evolution and rapid emergence of new information that should be incorporated in a nimble manner on a living, breathing site, such as a web-based practice guidance website. So we very much have an intention of creating just such a NASH practice guidance development that is updated on a continuing basis to meet the needs of both our patients and our providers. And then finally, I'll mention that that among the NASH resources that we will have made a profound commitment to invigorate will be online education, which will be free, covering the fundamentals of liver disease as they relate to the treatment and care of patients, particularly suited and directed toward primary care providers who will first encounter patients with fatty liver disease. And so we anticipate the launching of a NAFLD and NASH set of modules later this month on www.asldfoundation.org/FOLD, or Fundamentals of Liver Disease. So these are a number of the initiatives that AASLD is super excited about kicking off in the area of NASH, that represents a particular commitment to patients with NASH and patient groups, and we're very excited to kick off this new era. So thanks, Donna.
Right, thank you, and thanks for making some breaking news here on this webinar with the timing of some of the guidelines and the joint collaborations and the new education modules. So thank you. So you've already answered some hot questions that some of the other speakers and incoming questions. And I also want to take the time to thank you and thank AASLD for really putting, for walking the talk behind the strategic intention to do patient engagement. As a patient who sits on that patient advisory council and on the NASH task force, and having made suggestions and know the patients who sit on the COVID-19 updates, you've really stepped up and made that a reality in a very substantive way. That some organizations only play lip service to. AASLD has really lived that, and I really want to thank you for that. And so the only person who could possibly follow all of that robustness is Dr. Zobair Younossi, whose work is the most cited, most quoted on the topic of global NASH. And so, Dr. Younossi, will you set the stage for the rest of our conversation about what is the scope and scale of this challenge that we're dealing with?
Thanks, Donna, and thank you for taking the leadership to organize this International NASH Day with your organization. It has been quite a bit of an effort, and it really is a wonderful contribution to the field of hepatology and specifically NAFLD NASH. So thank you. I just wanted to remind people that this is a disease that is an important liver disease that is a reflection, a manifestation of what we are seeing around the world, which is the not the pandemic, but the epidemic of obesity and the complications, which is type 2 diabetes. So in that context, the prevalence of fatty liver disease, which is the more of a spectrum of different liver diseases, the encompassing title of non-alcoholic fatty liver disease, worldwide is about 25%. Now the prevalence is not unique in North America or Europe. You'll find it in all parts of the world. The highest prevalence actually in the Middle East and also in South America, and the lowest prevalence so far has been reported from Africa. It's about 13%. In fact, part of the problem, of course, with data from Africa is that there's not a lot of data available. But if you look at the data, say from Nigeria, the prevalence is about 8%. Now, when you look at the subgroup of patients that have diabetes, because diabetes is such a major risk factor, and this is really why Ray and others have actually partnered with the endocrinology societies and diabetologists, is because there is a lot of patients there. The global NAFLD prevalence in type 2 diabetics, this is from a meta-analysis we did a couple of years ago, is about 55% and maybe even higher. When you look at the progressive form of fatty liver disease, which is what we call NASH, and that's what NASH is. NASH is really a histological diagnosis. Steatohepatitis is a histologic diagnosis. You've got to have a liver biopsy to make the diagnosis of NASH. So in general population in the United States, and probably the rest of the world, the prevalence of NASH is about 1.5 to 6.5%. In the type 2 diabetics, that prevalence is about 37%. So a third of patients who have type 2 diabetes will have NASH. Why is that important? Well, it's because that is the subgroup that can progress to cirrhosis and its complication, including liver cancer. And in that context, now NASH is the second indication for liver transplantation in the United States. And in fact, in women, it's the number one indication for liver transplantation in the United States. Liver cancer, of course, we always thought viral hepatitis to be the major driver of liver cancer. Now we know that NASH is an important contributor to liver cancer. In that context, again, you can have liver cancer both in the setting of cirrhosis, but also in the absence of cirrhosis, although the rates are much, much lower. So when you look at the burden of a disease, of any chronic disease, the way I look at this, that we should look at comprehensive sort of burden. The clinical burden is where we hepatologists always look at, which is mortality, cirrhosis, liver cancer, etc. And certainly there's plenty of data that that's actually high in the world and is increasing. We have looked at global burden of disease database and different regions of the world, the GBD regions. And in fact, NASH is the only liver disease that both in terms of incidence of cirrhosis and mortality from cirrhosis and liver cancer is increasing in the vast majority of the world, while the other liver diseases are either stable or coming down, like hepatitis C. So that clinical burden, of course, is important, and we need to always pay attention to. But there are three other important burdens. The second burden, from my perspective, which is probably even as important, but probably from a patient's perspective, is more important, is what we call patient-reported outcome, which actually, which is a surrogate for patient experience. So, and we know that fatty liver disease, especially when you get to NASH and maybe advanced NASH, it has a significant negative impact on patients' quality of life. And the third impact, of course, is function. It's not only about quality of life, can they function well? What is their work productivity? And that's the third type of burden. And the last burden is economic burden of FAASLD. And we have shown that just when you estimate it very conservatively for the United States, the economic burden is substantial. It's in billions, hundreds of billions of dollars. So this disease has major impact on not only the patients, the family, the healthcare, but actually the society in general, not only in the United States, but globally. The tsunami that we are talking about is the fact that our kids are getting more obese. Our children has a prevalence of about 10 to 15%. And some of these kids are going to develop more advanced liver disease. There is a conundrum in this situation. One is that in order to understand this disease, which is very complicated, and it's a complex disease, meaning that there are multiple pathways that can lead into NASH, that there is not good non-invasive tests to make the diagnosis of who's going to be at risk to develop bad liver disease. So right now, if you want to know this for sure, you have to do a liver biopsy, but liver biopsy is not something that we want to do in large scales, obviously. And in that context, there is a lot of effort. There is an effort in Europe called Litmus, and also an effort in the United States called Nimble to develop biomarkers for diagnosing NASH without a biopsy, for prognosis, and for monitoring once the drugs are available. So in that context, we have some good algorithms, non-invasive tests that can help us to sort of enrich which diabetic patient population or which diabetic patient is going to be at increased risk for bad outcomes in the future. But we need to refine these biomarkers. We need to have better ones in the future so that we can actually use this in clinical practice. And the final part of the conundrum is that despite the fact that this burden is increasing all over the world, there is not good treatment for it. I mean, if you look at the root cause of this disease, which is obesity and type 2 diabetes, then lifestyle modification and management has been what we've been always suggesting over the past decade or so. But the problem is that, first of all, as you know, it's hard to achieve weight loss, and then it's hard to actually sustain it. So this is going to be a part of the problem, that we don't have good treatment. There are a few treatments, medications that are available, but there is a great deal of effort to develop a good treatment for NASH. And there are at least one drug that hopefully will become available sometime soon. But developing treatment for NASH, because of how heterogeneous this disease is also a challenge. And finally, I'm a big believer this is not a disease that you can treat just with one medication or by one specialty. It is a disease that requires a national policy. It requires a public health approach. It requires sort of partnering with societies and other stakeholders in obesity and diabetes sort of arenas. And then all of us, when we have these patients, we need to sort of put a multidisciplinary team together that includes not only gastroenterologists and hepatologists, but endocrinologists, diabetes experts, nutrition experts, exercise experts, and to just manage the cardiometabolic risk factors for these patients. Because remember that the number one cause of patients' death in fatty liver disease in the early stages is cardiac. In advanced stages, it becomes liver. So we need to really manage the cardiovascular risks of these patients in a team, in a manner that we have a multidisciplinary team in place. And for some patients, those that have significant scarring of the liver, and those are the patients that then you can then focus on the new treatment that will become available. So the burden is already immense. The way that obesity and diabetes is going up in the world, it's going to become even more of a problem. It already is consuming a lot of resources from us in terms of liver transplantation, liver cancer. Our clinics are now full of patients. And in fact, this is despite the fact that a large number of our patients are not seen by us. They're not even actually diagnosed. So having programs that Ray talked about in terms of finding those patients in the primary care practices and endocrinology practices and cardiology practices, and then linking them to appropriate care will be important. And once we approach this public health and strategy and health policy sort of perspective, not only for the United States, but globally, then we can find a group of smaller group of patients that would need medication and medical treatment. And those will be identified, those patients would be identified hopefully with non-invasive tests that are also being developed. So it's a challenge, but I think there is a great deal of activities going on, and GLI for spearheading this day to increase awareness is really one of the most important and key steps for this disease. Because yes, we can focus on our labs and our clinical research and other things, but at the end of the day, if you don't apply it to patients and then to the population in general, and really make a difference where policies are changed and the country to deal with this, we're not going to make as much of an impact. So I thank you, and that these were my comments. Thank you.
I thank you for the gentleman from Virginia yields back some of his time. So you have laid out quite the challenge for us. Let's try to break that down a little bit. And I'm gonna come to Pavel next. So we've talked about 1 in 4 people globally, but of variances in how country by country, geography by geography, the prevalence changes and the challenge changes. So Pavel, give us a sense of what this looks like in Russia.
First of all, I'd like to thank Donna to take part in this council. It's really a big honor for me to be not far from Raymond, Chung, and Zobair Younossi. Thanks a lot. And I'd like to say a few words about our situation in COVID and NASH.
Yes, please.
First of all, about half of our patients with severe COVID-19 demonstrated abnormalities liver tests. And maybe we can say now that NASH is a negative predictor of fatal outcome of COVID-19, like diabetes, like coronary disease, obesity, and other. And one very interesting moment for us, we can overcome our restricted health care system. Then we have used digital technology to monitoring our patients with chronic hepatitis C, chronic hepatitis B during antiviral therapy, and NASH. But NASH is a great chance. We clearly understand it's a most common liver disease, and for us, it's a great chance to create multidisciplinary approach in Russia. Usually we are very separate, hepatologist in other side, endocrinologist in other side. So NASH, NAFLD, it's a great chance for us to create multidisciplinary team. And then we talk about diabetes. We have to clearly understand just 4.5 million patients in our national register, and they think it's about half of really number of our patients with diabetes type 2. More than 50% of them have not diagnosed. Then we talk about Moscow region. There are 220,000 patients with diabetes type 2.
Mm-hmm.
About a third of them demonstrated cardiac disease. About 70% of them demonstrated obesity. And more than 60% patients with diabetes type 2 have obesity and high blood pressure. So, on the other side, we know that about 18, maybe 95% of patients with obesity have NAFLD, and more than half of them NASH. So, a lot of patients with diabetes, with obesity, in our endocrinology departments need to get hepatology service from hepatology department. We have to create multidisciplinary approach, but it's a pity they have not any guidelines right now. What they have to do? One moment, I forget to talk about 10% with HBV infection, and more than 10% of them have got incorrect prescription of antiviral therapy. Why? We have low viral load, but we have high level of ALT. So it's a problem for Moscow region. I think not only for Moscow region. What we have to do? First of all, we implement patients and family learning center and our federal standard of management patients with diabetes. It's we need it now. Patients need it, but we need implement this approach to other patients, not only with diabetes. So I hope maybe in the future we can implement fitness in our state insurance system, mandatory. We need it. We need to get instrument to lifestyle modification for patients without diabetes, or patients with obesity. And I hope we can create new policy in our new food policy. We have to restrict intake food supply with fructose. I think it's only government policy, and very important for us to get a new guideline for management patients with NASH.
Well, you heard it's coming. You heard it. You heard it's coming now.
Yeah. I hope it will help us.
I want to ask the question because so Zobair talked about biopsy proven NASH, but what I've heard several of us discuss and across the panels today about a very much risk-based approach to looking at if a patient has overweight or obesity, if they have diabetes, if they have high cholesterol, then it's quite likely that they would have some degree of NAFLD or NASH and should move towards screening. Should we really be thinking more about, and this question is for Zobair and for Pavel and Ray, should we really be thinking more about these risk factors and risk-based screening with sort of biopsy, for just certain circumstances, and really change how we think about and how we define NAFLD and NASH? Is that where we're moving towards? Because we can't scale up biopsies for everybody.
Yeah, so I'll make a couple of comments. I think the idea of biopsying everyone is probably not practical, and it's not possible, and it's not necessary. So I think what we are going to do in 2020 is to utilize the algorithms that we have. So there's, for example, one algorithm called FIB4. If you take those algorithms, especially in the context of risks, so if you put multiple component of metabolic syndrome, if you're a diabetic with visceral obesity in a slightly older age, the likelihood of having fatty liver disease is over 90%. So you have fatty liver. In fact, the more component of metabolic syndrome you have, the higher the chance of having fatty liver with fibrosis, and the higher the chance of mortality from NASH. So that we know. So you actually, when you look at this risk profile, and then use some of the non-invasive tests that are available, so the algorithms, for example, to enrich the population. In addition to these algorithms, you can use something that will measure, say, stiffness of the liver. We have a number of those things, elastography, point of care, very easy to do. In 10 minutes, you get how much fat you have in the liver. It's not perfect test, but it is actually pretty good to enrich the population. There are some blood tests that are being developed. One is called ELF testing, which is available in Europe, which actually measures fibrosis. So FibroScan ELF, you use two of these measures in the context of what the patient has. You have a pretty good idea if the patient has fat and fibrosis, which to me, that's the most important part of that. You have fatty liver disease and you have fibrosis. Why is that important? Well, because stage of fibrosis is the only proven surrogate for predicting mortality. So if you want to look at one thing in terms of these patients, it's fibrosis. And if we can actually do this without a liver biopsy, which we can't do it perfectly, but we can get a pretty good idea right now for most of these patients, then you avoid liver biopsy for a large number of patients. And I think the liver biopsy should only be reserved. I'm a member of the AASLD guidance document, at least the last one, the 2018. We recommend that you do a liver biopsy if there is another potential liver disease, like an autoimmune liver disease, in addition to fatty liver disease that you're suspecting, or that you have a patient that basically is going to go for a clinical trial because it's required. Most of the other patients are not going to require a liver biopsy, and I'm hoping that that becomes less and less as we develop better and better biomarkers.
I hope that too. And that's why, GLI partners, as you know, with the FNIH Biomarkers Consortium, the NIMBLE Consortium, and talks with our friends at Litmus. But I want to bring Marko into this conversation because we've heard that all of this awareness and even the clinical work is great, but if we don't have the policy to support this, then it's all for naught. And I know that's where you excel and where you started having the first sort of NAFLD-NASH summit and talking to members of the European Parliament. So Marko, tell us about the work that you've been doing and how we can move this forward with policy.
So thank you very much, Donna. And first of all, congratulations on GLI to have this event and to have us here all together. I'm super excited to see familiar faces here that really make a difference in the NASH world. I remember we were together with Dr. Younossi in Geneva 1.5 years ago, and the challenges are still the same. So in Europe, we have a problem because every country has its own healthcare system. So we have like how many countries there are, we have so many problems and so many different advocacy approaches. I just wanted to also congratulate the AASLD. Several years ago, I was invited also to have a small chat with the management and we said that it would be good to include patients, and they made some huge steps forward. And when they brought on board also GLI, I think they did also a major step forward. I agree with Dr. Younossi regarding the biopsy and non-invasive tests. I am very much for this test, and we are doing advocacy to have more research funds to research non-invasive tests, also from the personal perspective, because as I am a patient with liver disease, I cannot have a biopsy, but I had problems with the liver. So we have similar patients that needs attention. And when we discussed International NASH Day with Donna a few months ago, we decided to have this webinar and to have actions because maybe it's now the right time to also shift the focus from COVID-19 and to gather all the learnings from the COVID-19 and to show that there are liver patients who really need attention. We agreed that we need attention on COVID and to restrain the spread and everything. But in this process, we discovered also some major players in healthcare system, some major communication points we can use also for other diseases as NAFLD and NASH. And regarding the patient advocacy and collaboration, Nash has brought on something that was never here before. So we were working like in the silos. So if you were working with hepatitis, you were working with hepatitis. If you were working in liver diseases, you were working just with liver diseases. But NAF and AASLD has brought us another major issue in patient advocacy, and that's communication with other patient groups, like patient groups from cardiovascular field, and everything that Dr. Chung already said that they did on a level of doctor to doctor. We need that also in patient groups, and I think this is going to be a major step forward. And regarding the treatment, yes, unfortunately, Dr. Young, when we met in Geneva a few years ago, the situation was for patients, there's only lifestyle change and food and beverage change. And today we are still on the same level regarding the possibilities of the treatment. So we as a patient representative, we really are keen to having anything that we can offer also to patients, because as you already stated, it's very difficult to lose some weight. You can lose some weight, but then it's really difficult also to maintain it. But for now, there's only two possibilities, and as you said, the lifestyle change and changing the food and the diet. And I would just end with one difficult point for patients, especially in Europe. So having one doctor taking care of you. So in the field of NASH and FAASLD, we have different specialties that are in this field in Europe. So I, as a patient, I never know, is dietitian the one person I should go to, or is someone with liver disease specialty the one I should go to? So we have different countries and different specialities in the medical field that are tackling NASH. So I would really hope that you could come to an agreement who's the main doctor for a person with NASH, and then we can work from there. Of course, we need multidisciplinary teams and people with different specialties, but I would really like to have just one doctor that I had to go to, not several bunch of them. So thank you.
You know, Marko, I want to pick up on that point because as a patient with multiple chronic diseases, I'm often asking that question, who is, if I use the term from American football, who's the quarterback of the team? And there's a body of literature, you know, about, you know, how it shifts due to, you know, which condition is sort of the most you know, problematic or prominent at any given time. And I wonder if, in the case of NASH, if someone is who has both diabetes and NASH, if then the endocrinologist who they may have had the longest term relationship with becomes the quarterback of that team and then connects in with hepatology and others as needed. Or if you are a more advanced patient with cirrhosis, for example, then the hepatologist is really the quarterback or the coach or the manager of that team, is sort of on point for the patient. And I think that's something that certainly as a patient I'd love to see, and I'm starting to see more work between the specialties, sort of figure out what those thresholds are as you change, you know, sort of who's holding the baton. I'll mix my sports metaphor there, but who's holding the baton, or who's the quarterback, or who's the point person of the team in any given time, you know, based on you know, which of the conditions is most prominent. I think we're going to have to see that that change in disease management and that sort of fluidity. And I see you, certainly when you said it, when I see in various places like New York and different areas of the US that are setting up fatty liver disease clinics that have sort of everybody in one spot, I think it's probably easier to do in those places. I'm sure, Ray, they have that at, you know, at MGH, you know, so that it is easier to bring in the multiple specialists, you know, on a case, and make them accessible to a person, and have those handoffs between physicians in a way that's convenient and makes sense, and a sort of one-stop shop for the patient. So, Ray, do you want to talk a bit about that, and then we'll do a round?
Very briefly. I just to that point, I couldn't agree more with the concept of individualization of care using a multidisciplinary team. To the extent that that's possible, great. But there are certainly those who don't have access to these, perhaps these academic centers that have all of these specialists together under one roof. And so what COVID has wrought in many ways is a movement toward virtual care and toward the use of technology like we're using right now, as a matter of fact, to communicate across broad locales. And I think that we should exploit as a means of taking that quarterback and communicating with his or her care team and getting the specific opinions regarding the endocrinologist's opinion, the cardiologist's opinion, because that patient's cardiovascular risk is dominant at this moment. And so I think that we could craft an individual solution using whatever tools are available to us, including, I think, the use of technology to bring specialists together. Is something like what we do with tumor boards, for instance, and having folks discuss cases jointly, and then coming up with unique solutions.
I think that's a great model. So as we wrap this up, and I'd love to give everybody the opportunity to give one solution, because we've outlined a lot of challenges, from lack of awareness to complexities of disease to biopsies and non-invasive technologies still evolving, to the need for multiple policies and everything from food policy to healthcare policy and coverage and drug development. So we've done a good job of laying out the challenges. Maybe I should have changed the name of we need another panel on the solutions, but maybe if we can start that conversation as we go around. And Pavel, I'll start with you. Your top sort of solution for this global challenge before us in NASH. Let me make sure I unmute you. There we go.
I'd like to
one thing.
I'd like to say a few words about our experience use GLP-1 in our practice, in patients with diabetes type 2 and NASH. I hope not only government policy, but our knowledge, our experience to use any drugs, any medicines in our cohorts patients can help us to create new approach to treatment this patients, not only with diabetes, but with NAFLD. So first of all, we need more data to create new approach, more data, and I hope our multidisciplinary team, absolutely agree with my colleague, can help us to create this new approach, not only government policy, but our approach in our routine clinical practice.
Excellent. Marko, your one thought for us, one solution for us?
So thank you very much. When I was thinking just of one thing, I would just highlight the collaboration. I think the COVID-19 has shown that you can really make major steps forward if you have all the stakeholders on board. So the highlighted word would be just collaboration.
Right. Ray, we'll come back to you, give you another shot at the one solution, and I'll give the last word to Zobair.
Well, I think,
I'm sorry.
Go ahead, Ray.
I'm sorry. So what I'd say is multidisciplinary work is all wonderful once you have a diagnosis, once you've identified the case. And so it's awareness. It's awareness of the epidemic as it stands, that it's around us. And so reminding patients and providers alike that it is there and that we need to identify those cases. And so screening or particularly honing in on those at risk should be an important message that gets us started on this path.
Great. So Zobair, our solution.
So I think I think with technology we'll have better diagnostic tests, better treatment. Using echo model for telemedicine for multidisciplinary team, all of these things will come. The one thing that's going to make a difference or not is how the policy towards this disease is going to be established. How much attention do we give there? If we have all of those great things, but no one wants to pay for it, or it's not the priority of other priority for funding and focus for national policy, then we're not going to get there. We have examples of diseases that are much less prevalent, but are much more focused in terms of policy strategies that you get a lot more accomplished there. So if I have to say one thing, it's going to be the national policy in every country and probably global policy around NASH to consider it an important disease and really start more and more funding that will bring all the other innovations in terms of screening and telemedicine and diagnostics and treatment. But I think that's what we need as the number one priority from my perspective.
Excellent. Well, more policy is what a lawyer always loves to hear. So I will take that as an answer. I will also, remind people that our virtual Hill Day is ongoing. And so this year, at least in the US, you can send messages and notes through the globalliver.org website to your members of Congress. And Marko, we look forward to working with to expand that to the EU Parliament and to other national governments in the same way. So I'll just take this opportunity for this NASH as a global public health challenge and solution panel to say thank you to all of you. Thank you to everybody who has watched and listened either directly on June 12th in real time or at a later time at your convenience. Whenever you are watching, we thank you for stepping forward and participating and for the actions we hope you'll take in the future. So for information of all of the panels that we've had today on pediatric NASH, on non-invasive technologies, on NASH and obesity, and the next one to come, NASH and liver cancer. The information is on the globalliver.org website. Also on the website is an interactive map of the activities of all of our partners, like ELPA, for example, that are going on today and are providing a surround sound and really making International NASH Day a true global effort and movement. And so with that, I say to everyone, stay safe, be well, and share what you've learned here today. Thank you. Thank you, gentlemen.